Okay, let's get started. Welcome everyone, and my name is Shuaib. I'm the course organizer for BitePACES, and we've been running a free webinar series, as I'm sure many of you know, over the last couple of months, and we're continuing to do so. So today marks the first webinar in our December series, where I'll be going over what sort of things you should be doing to prepare for the next diet. And we'll also be doing neurology and ophthalmology and clinical consultation webinars, and you can find out all about that on our WhatsApp group, which I'll post a link to. But before we get started, we are running courses next diet in January and February. I don't think you guys have found out your dates yet. But if you do book onto the course, the dates are flexible, so you can move between the dates depending on where your exam falls. We have a 1 day and a 4 day course, and we have some really nice cases. And you'll always be in small groups of no more than two per group. So please do come along. We've received some really good feedback over the last series of courses. So these are our Google ratings. And if you ever have any questions, you're welcome to drop me a message. Join our WhatsApp group. You can find out all about our free webinars there. And the top right is a link to our website, www.bitepaces.com. Good. So I have done this webinar previously. As I've changed it around a little bit, but basically we're now approaching January. We've got about two months. Some of you might have 3 months till your exam, depending on where it falls in the diet. So this is a good time to start knuckling down, which is why I'm doing this webinar. And it's just to emphasize that PACES is quite daunting, but it is a game, and it's not. I think where people fall short is that they try and do what they would do in clinical practice, but it's not about what you would do, it's about what you should do according to the examiner. So it's a bit of a game, and you need to know how to play it. And sorry, I forgot to say, so not all of you might know me. So for context, I I'm actually a radiologist, but I passed my PACES a couple of years ago, and I've been doing lots of PACES teaching since, really. And I've spoken to a bunch of candidates, and I kind of highlighted a few areas where they fall short, and I think this is definitely one of them. It's just not picking up on that exam technique. In terms of stats, the pass rate is approximately 50%. So, it's not great, but I guess 1 in 2 is quite low for an exam. Sadly, IMGs do tend to do worse, and this is probably due to cultural nuances, communication barriers, etc. So that's something to highlight and to really work on if you are an IMG. The poorest performance in the exam is typically identifying signs or differential diagnosis. So what I would say to this is don't make up signs. That's like the worst thing you could do. If you have the choice between missing out a sign or making up a sign, I would miss out the sign, and both aren't great, but I think it looks worse to make up signs. Differential diagnosis, I'll give you a few tips on how we can tackle this, but I always say 3 differentials for each condition. So, I mean, time frame, you guys have actually got months, so we're in good hands. You've got plenty of time. Don't feel panicked. Now is a good time to start if you've not already started, and you're not falling behind. That's basically what I want to say here. Where do you start? Start with examinations. Examinations are the bulk of the exam. They feature in every station bar the communication stations, because obviously you'll be examining in your clinical consultation stations as well. There's no excuse. Your examination routines need to be slick. If they're not slick, and when people come on the course, it's obvious those who've practiced their examination routines and those that haven't, and that's not to judge anyone, as obviously everyone's different stages in their preparation. But my point is, it comes across. If you've not practiced the examination routine like 50 times, it's obvious. Just practice it on friends, family, pillows, teddies, whatever it might be. You just need to get the spiel and the movement sorted. And that should be from neuro, so cranial nerves, upper limb, lower limb, um, cardio, abdo, resp, just make sure they're all nailed. And the routines, you don't need to do anything wild or wonderful. It's just the standard routine that you're used to, probably from medical school. People are always asking me questions like, should I do this sign or that sign? Just stick to the absolute necessary and what you need to do. If there is a technique which elicits a finding, don't do it in multiple different ways. So what I mean by that is hepatomegaly. There's lots of different ways you can elicit if a patient has hepatomegaly or not. Just pick one. You don't need to do the scratch test. And, if you've done palpation and you felt it, why bother with the scratch test? Practice every day on healthy individuals. So this is what you should be doing at this point. If you haven't already, you need to nail it, get the instructions down. Make sure you have it down within 5 minutes, because if you're doing it within 6 minutes now, in the exam under pressure, you want to give yourself a little bit of leeway. Have a checklist for common things that you want to go through in the examination routine, always starting off with introduction, washing hands, and then, going through each key point in every examination. If you want, you can film yourself if you don't have anyone with you, and just figure out what works for you. So like for me personally, in the respiratory exam, I like to start on the back. That's where the money is, and that works well for me in my examination routine. Other people like to start on the front, and it's not wrong, but I think it's better to start on the back. But you need to figure out what works for you, and there are many ways to examine a patient, and there are many correct ways to examine a patient. Like I said, don't cram every possible technique in. You need to just cover the key areas. And by the way, feel free to ask questions in the chat or message me personally as we go along. Um, for every station, you need to have a list of cases which are likely to come up, and we'll go through these in a bit. And um, I have a list of cases based on what candidates have told me in the past. And, that's not me trying to disseminate information. That's literally just me speaking to candidates, and it comes up in conversation. And I think it's useful just to get a flavor of what comes up. So now you've prepped your examination routines. Now you actually need to go and see pathology. So once you've prepped your examination routines and you're slick at them, go into the wards, and using your list of cases, try and find every single one of these cases. So if you know, like, okay, I know in cardiology, it's likely going to be either a heart valve or a heart murmur, or congenital heart disease, a bit more rare. So on the Monday, I want to go and listen to 5 murmurs. On the Tuesday, I want to go and now do neuro. So I want to look at, 5 Parkinson patients, etc. Try and group cases in that way. I know it's not always possible, and it's actually quite difficult on the wards, which is why a course is useful. But try your best to do it as such. Join your WhatsApp PACES groups, go around with your colleagues. And I know some of you are probably doing it solo. I wouldn't worry about that. Like I did it solo. I was locuming in A&E when I did my PACES. So I wasn't an IMT or anything. So don't feel disheartened if you're in that situation. Try and find the PACES group in your hospital. Email consultants and see if they can be of help. In fact, just recently I had a colleague of mine who is a radiologist who sat PACES in this recent diet, and she found our local PACES group in our hospital and did it that way. So, there's definitely ways around it. Email consultants, this can work. It's a bit hit and miss, but, email general medical consultants for interesting cases. You just have to be resourceful, stay late. Unfortunately, it's not the most efficient process finding patients on the wards, as I'm sure you guys have come across, but you just got to try your best. And be focused, like don't waste your time. If you can see a patient is not amenable to examination because they're too unwell, or maybe there's like a significant language barrier, like just I wouldn't waste your time. Every patient you examine in the hospital, you need to get in the mindset that needs to be adding something to your preparation. And if it's not adding something, then just move on. Okay, so once you've prepped your cases, you've prepped your examination routines, you've seen some pathology, you now need to get familiar with the viva. And what I would do is I would prepare a list of common questions for each common case. So if we take respiratory, for example, I'm going to have a list of questions for ILD, then a list of questions for bronchiectasis, a list of questions for COPD, for lung transplantation, etc. And you're always going to have the standard questions of present your findings, what are the common causes, something about investigation management, but then you might have more niche questions for each case. So for aortic stenosis, you'd be expected to know the echo criteria for severity, for example. And this is an easy thing. You can practice this before you go to bed, right? You can just have a list and you can just recite the questions and the answers to yourself. You can film yourself if you want to be a bit more, put yourself under a bit more pressure, or do it with colleagues at work. That's the best way to do that. So clinical consultation is daunting for a lot of candidates. It's really not that hard, I would say. But a lot of candidates do slip up on it. And when I say it's not that hard, that's not to criticize anyone that may have slipped up. That's just to say that actually, when you break it down, it's literally probably what you do in your day-to-day work in ambulatory care. But obviously, under exam pressure, it can be quite challenging. And a lot of candidates do slip up here. And sadly, this can really affect your performance because, as we'll come on to later, the clinical consultation tests all 7 domains. So you're tested across the breadth of PACES mark scheme in the clinical consultation station. And as you know, if you fail on any one of those domains, you'll fail the exam, even if you pass, even if you get above 136, but you failed in a particular domain, you will fail the exam. So this is, you need to nail clinical consultation and make sure you're scoring highly in this. Again, I have a list of cases and I've kind of got more of an idea of what's come up recently. But what I've noticed is that back in the day, we used to do this thing called the station 5 as like short cases. And those short cases would be kind of like spot diagnoses. So for example, in my exam in station 5, this was in 2019, I had sarcoidosis. It was like a lady of African origin. She had dry eyes, she had erythema nodosum, she had a cough. It was like quite classic. And then I had an acromegaly patient. Again, it was a spot diagnosis. Whereas now, what I've noticed is that we're moving away from the spot diagnosis and more into general consultations like fatigue, anemia, headache, loss of consciousness. So the exam is more moving in that direction when it comes to clinical consultation. So be aware of that. You can have a bunch of scenarios and practice with colleagues over Zoom, and just be sure to keep to time. Communication is the next part of the exam. Sorry, not the next part of the exam. This is the next bit that I would prepare. Most people will probably do okay with this, particularly if you've trained in this country and you went to university in this country. You're at a big advantage. I wouldn't neglect it, but this is the thing that I would do after I've really nailed my examinations and clinical consultation. Have a list of cases, but it's your classic Breaking Bad news, angry patient, medication error, explaining a treatment or a management plan to a patient. So it's all stuff you're familiar with, but it's just, again, never word things the way you would word them in clinical practice, because the way we word things in clinical practice is a bit, it's obviously not proper when it comes to exams. You need to have a system of communication when it comes to exams. You need to make sure you're asking open questions to begin with. You're summarizing, you're chunking and checking, you're doing ICE throughout. You're then, if needed, summarize and icing again. You need to make sure you tick all of these boxes. Whereas in reality, in clinical practice, you might not do things to that extent. Again, this is one along with clinical consultation. There's no reason why you can't practice over Zoom. Very easy. A lot of the patients may well even be actors. So similarly for clinical consultation, sometimes the patients are actors. So it's definitely something you can do over Zoom. Have a script, keep to time, and remember these basics, like I said. And again, this is where I think people who haven't trained here struggle, particularly when it comes to things like using jargon. So if you are an IMG or trained abroad, just make sure you should spend more time on the communication and clinical consultation sections. And this is one way you can prepare. So this is like a DNA CPR spiel. You can take a picture of it if you want, but DNA CPR is a really common one that comes up in the communication station, and you should have a script for all of the common things that could come up in comms and how to explain them. So DNA CPR would be one of them. Explaining common treatments or investigations like echocardiograms, MRIs, CT scans, that sort of thing. But DNA CPR in particular is one, and advanced care planning is one that comes up time and time again. Again, if you join the WhatsApp group, we post this sort of stuff in there. And it's not just about practicing with colleagues and examination routines, but there is some reading that you should be doing. I'm not a huge fan of big books. I'm not sponsored or any at all or have any leg in the game, but my personal preference is Cases for Paces. I use them. The book is about this thick, but it's probably the most highest yield book that you could read when it comes to paces. And I think it really gets you in the mindset of good exam technique. A big hurdle that PACES candidates fall into, and I would say just please don't fall into this, is almost over preparing and over reading. Like really getting into the nitty gritty. You don't you want breadth of knowledge and you want to come across as slick. No one's asking you to know aortic stenosis inside out, right? Like, but you need to know the basics of like echo criteria, how it's treated, conservative medical, surgical, etc. Don't get caught up into like really niche things or like niche diseases. Common things are common, and in PACES, again, having spoken to people who even sat the exam recently, the bulk of it is stuff like ILD, nerve palsies, heart valves, Parkinson's disease. And if you go into a station, you start quoting like one random diagnoses, that's where you're going to slip up. Because remember, I said most people fail on identifying signs and differential diagnosis. Yeah, you can use a large textbook if you wish. That's kind of your personal preference. There's some really good YouTube video content out there, which is free. So one thing that I used previously was Dr. Punika's YouTube content. It's probably quite old now, but he did some really good cases on YouTube. And there's also paid video banks, as I'm sure you guys are aware, things like Pass Test, etc., which people seem to really like. And courses, so of course, we run our own course, and I'm biased, so I won't talk too much about that, but you're more than welcome to come. Common pitfalls, poor timekeeping, getting flustered. And a really common one is, and I've heard this recently, like candidates tell me, like, I completely messed up this station. And that's fine. You can actually do badly on a station and still pass. So what you can't do is do badly in a domain, which we'll come on to later. If you mess up a station, as easy as it is for me to say, you just need to move on because if it affects the rest of your performance, you're kind of screwed. So you just need to get your head back in the game. You're still very comfortable. You can still very comfortably pass. Um, yeah, so just keep going. Not keeping it simple, like I said, getting bogged down in complex diagnoses, getting bogged down with like really niche investigations. Just think about, your examiner is not a specialist. The person examining the patient with Parkinson's disease probably doesn't know that much about Parkinson's disease, or probably doesn't know as much as you do. So if you just want to come across as slick and competent, verbal diarrhea, avoid at all costs. This is one thing I've really noticed in people's presentations, again, having seen kind of hundreds of candidates go through the course. And yeah, you need to keep it concise. Your presentation just needs to be slick. And I'll show you the way I like to present. But no one wants to hear about every single negative sign. Like if you should know in your cardiology station, the patient likely is not going to be in acute heart failure. So instead of saying, okay, these are my findings, and my negative findings are the patient doesn't have a raised JVP, they don't have crackle suggestive of pulmonary edema, they don't have pitting edema, just say the patient doesn't have any signs of heart failure, right? That's it. Similarly, avoid language like I think I heard this and it could be this, and possibly there was a hint of like no one wants to hear that. It either is or it isn't. And if you're not sure, then yeah, you are a bit stuck. You need to figure out a way of saying it. And there are ways that you can word your presentation to help you with that. And that's something we can discuss probably in the Q&A if you guys want me to. Not developing patient rapport. So yeah, it's all an act. Be enthusiastic, be friendly to the patient, don't hurt them, the standard sort of things. From the examiner's perspective, and again, like I said, having seen well, not tons, but seen loads of candidates examine patients, you lose concentration after like the first 30 seconds. If your first minute is super slick, I know this candidate knows what they're doing. You kind of switch on as an examiner in the first minute and probably when the presentation starts, and everything in between is a bit of a blur. So if you look really good to begin with and you end really good, no one's going to mind too much what happens in between. Obviously, don't mess up, but beginning and the end are the most important bits. Systematic approach. This is why knowing your examination routines and your communication systems inside out is non-negotiable. Clear and concise presentation. So that's what I was saying about how you end it. Well-formulated differentials. So I only ever want to hear 3 differentials and no more. And if possible, no less. I want 3 differentials for everything. And just the examiner wants to see that you're responding to the patient's cues. So, if they're in a little bit of pain with a particular movement, just pick up on it. Um, and yeah. And before I forget, and this is a bit random, but someone asked me this question, and I think it was a really good question. Um, there's always a thing like, should you talk aloud as you go on, or should you be quiet? So I would say be quiet and do it silently, but interact with the patient in a way that you're actually telling the examiner you know what you found. So an example of this would be there's a tiny scar on the abdomen, which is indicative of like, maybe they've had a drain or something. So what you can then do is like you say to the patient, oh, I noticed you've got a scar there. I'm just going to have a look around to see if there's any other scars. So now you've told the examiner, you know there's a scar there, but you're making it seem like you're actually talking to the patient. So these are little tricks that you can use. It was a bit random. It wasn't really related to this, but I'm just remembered it because someone asked me. Yeah, it's a bit of a mental game. Honestly, don't worry if you failed before. There's so many good doctors who've failed and are far, far better doctors than certainly me. But it's all about exam technique and, partly what comes up on the day. It's just one of those things. But by this point, if you follow this sort of structure of getting your examination routine slick, going onto the wards and finding those common cases, prepping your vivas, prepping your communication consultations, then you've done the hard work. Stick to the basics, keep it simple, and that's all you can really do. I've gone through this before with some of you who may have come to my previous webinar, but like this is what your normal day looks like. You get a bleep, deal with an angry relative. Okay, now you need to go clerk a patient with syncope. Now you get another bleep, and the patient wants you to explain a diagnosis. Okay, now you need to clerk a patient, and now I need to clerk another patient. Now you get another bleep to deal with some medication side effect. And this is essentially what the PACES exam looks like, right? But here's what it looks like on the ward. And when you're on the ward, you cope with it completely fine. But when you're in the exam under the pressure, it's easy to succumb to that. But just remember, you guys do this day in, day out, and you will be fine. Station 1 is RESP followed by comms. So the way communication used to work previously is you'd have a whole dedicated station for it. It'll be 20 minutes long. Now it's just a 10-minute station with no examiner interaction. So you're not going to get vivid in your communication station. They're really, they're just looking to see, can you follow those basic things like the communication system of, are you asking open questions? Are you responding to the patient cues? Are you icing? And obviously you need to have some knowledge because some of the communication scenarios that come up require you to know some background knowledge around things like DVLA rules, for example. And again, there are things, if you don't know, there are certain phrases and things you can do to get out of that. And that's something that we do go into in our course. But, if you have any questions about it in particular, you can ask me at the end. So common cases that come up in RESP. And this is having, spoken to a lot of PACES candidates, kind of narrowed it down to this list. Even recently, I was speaking to a guy the other day and he was telling me he got ILD in the context of rheumatoid arthritis. ILD is by far the most common. Sorry, just eating my chocolate. ILD is by far the most common. After that, probably COPD, lung transplant. We've got a really good lung transplant case on the course, actually. This is something you're not going to see every day, but it's just one of those things that comes up in PACES. Bronchiectasis, scars. Don't miss these scars. They can be really subtle sometimes. Buried underneath the armpit, and sometimes candidates miss them, and it's a big shame because if you miss the scar, you're kind of screwed. And less commonly pleural effusions, but by far ILD is the most common. So how you, if I want three differentials for every case, let's say you have an ILD patient, what three differentials, how are you going to structure your differentials? Because sometimes it's just barn door obvious this patient has ILD. So let's say you come into the rescue station, you have heard fine bibasal crepitations. They haven't got any signs on their hands. They've got no other signs, but it's obvious to you, they've got restricted chest movement. They've got bilateral fine crepitations at the lung bases. They look slightly short of breath. To you, this is obvious fibrosis or interstitial lung disease, rather. How are you going to give me? Remember, the key place where people slip up is differential diagnosis. So, how are you going to give me three differentials in this particular scenario? If you just type some in the chat. Oh, sorry, I just realized you guys can't actually chat with me. Apologies. I've just changed that. So you should be able to yeah, you should be able to chat now. So fire away. Differential diagnosis for ILD. Um, so we've got discussed common causes of ILD. Yeah. So like I guess what I'm trying to get at is I think where people can slip up with differentials is they start kind of going down the wrong path. So it's ILD and you'll say, this is most in keeping with ILD, but it could be bronchiectasis or it could be pulmonary edema. Well, yeah, it's true, but those are quite different diagnoses. So in the instance where it's like quite a barn door case of something, I would then phrase it like, this is in keeping with interstitial lung disease with a lower zone predominance. My differentials for a lower zone predominant interstitial lung disease include, idiopathic pulmonary fibrosis, et cetera, et cetera, et cetera. But I that's the way I would do it because people sometimes get confused or they ask me like, how can I give three differentials for something like which is just really obvious? But usually you can. So even let's say Parkinson's disease, like how can you give three differentials for Parkinson's disease? Well, you can because your examination findings are not conclusive for Parkinson's disease. Your examination findings are conclusive for Parkinsonism, of which the differential is idiopathic Parkinson's disease, but also Parkinson plus syndrome, or Lewy body dementia. It could be on a spectrum of disease, right? So that's the point I'm trying to make here. The other part of is communication. So these are kind of the scenarios that I've encountered in the past. Explanation of a new diagnosis, so diabetes, or recently Guillain-Barré syndrome came up. Explanation of a treatment such as a peg insertion, mistake in a treatment. So this is kind of your angry patient. So giving insulin when it shouldn't have been given. Dealing with an upset relative is a very common one. Breaking bad news to a relative that their family member has been involved in a road traffic accident, for example. DVLA rules, you should have an overview of the kind of DVLA rules pertaining to strokes, um, you know, acute coronary syndrome and seizures. So what you might have is a scenario where a patient comes in after having a stroke or a TIA and they really want to drive and it's your job to tell them that they can't. Or, you might have a scenario where they're like a lorry driver and, them not driving is going to take away from their living. Genetic counseling, breaking bad news, refusing to take medications, that came up recently. So this came up in a couple of people, actually, this diet and it was two people specifically, but it was a patient who was worried about taking statins as it might cause myasthenia gravis. Um, Clinical consultation, I think we've gone over kind of what it used to be like before. So it was like more of a spot diagnosis, but now we're changing more to the general workup and clinical consultation assesses that. It's a 20-minute station, so full 20 minutes on clinical consultation, yeah, and you've got two of them. And it tests every single domain. So this is like a super important part of the exam. Before the station, you'll get a brief and it'll be some sort of referral letter from a GP being like, please, can you assess this patient who presents with 2 weeks of fatigue? These are their thyroid function, these are the full blood count, etc., etc. And then your job in 15 minutes is to take a history, examine, and respond to the patient. And then you'll get quizzed for 5 minutes. These are often quite vague. Okay, so just to give you an idea, things like recurrent chest infections, poorly controlled hypertension, syncope, very common, first fit, anemias, weight loss, dizziness, unsteady gait, fatigue, cough, loss of libido in the context of a prolactinoma, men's syndrome, TIA. So it's broad. And it's a sort of thing actually you're probably quite used to seeing, in your clinical practice, a lot of these vague presentations. So what you need to do is you need to make sure you cast your net wide. You're doing a good systems review, and often you may not have nailed a diagnosis at the end of it, but you want to show that actually you know how to properly investigate a patient with syncope. So, um, you know, with syncope, are you considering neurological causes of syncope? Are you considering cardiac causes of syncope? Are you considering vascular, like postural hypertension? Are you considering endocrine causes, like does this patient have an adrenal insufficiency, for example? Um, just showing the examiner that you're fit enough to become a medical registrar and really dig deep into each of these presentations. And actually, for context, although my exam was before the era of clinical consultation, I had a lady, I think she had, from memory, adrenal insufficiency, which was causing her to get kind of postural hypotension and pass out occasionally. Um, so yeah. Station three is cardio and neuro. Again, it's the same story. 6 minutes to examine, but you should try and nail your examination in 5 minutes, and then you have 4 minutes to present. And if you finish your examination early, you will not need to present early and get vivaed more. You only start your presentation at 6 minutes, just in case any of you had that question. Cardiology, by far the most common, is some sort of valve replacement. So aortic, mitral, perhaps both. You might have a murmur. You might have a murmur with a valve. The key things with valves are to know that the difference between a functioning and a malfunctioning valve. So obviously, if the valve is functioning, you might get a flow murmur, but you shouldn't get a regurgitation murmur. If they have signs of heart failure with a valve replacement, then you could also postulate that it's failing. Other things, heart failure, congenital heart disease, dextrocardia came up really interestingly this year in one person's exam that they spoke to me about. And we actually had a nice case of dextrocardia on the course, so they were grateful that they'd seen that before. But this one can catch people out because it's a young patient who's probably quite fit and they have nothing on examination. And sometimes you can even still hear the heart on the left, even though it's on the right. But obviously you'll hear it louder on the right. So if you're in that situation where you have a barn door normal examination, just think, could this be dextrocardia? And the way to not make yourself look foolish, because sometimes it might look a bit weird, like why are you listening to the heart on the right? You just explain to the patient, just say, I want to have a good listen to your chest to make sure that your heart's in the correct position. That way you've explained to the examiner that, that's what you're checking. Neurology, neurology is quite vast, but again, the way I would break this down is by region affected in the nervous system. So, is it going to be brain? And if it's brain, are we talking upper motor neuron? Are we talking extrapyramidal? Are we talking cerebellar? Brainstem's unlikely you're going to get something brainstem related in the exam. Is it then something spinal cord? And if it's something spinal cord, which pathway is affected? Is it something in the peripheral nervous system? And this is how I would think about breadth of neurology. And again, common things that come up in the exam. I've got a list here. You can take a picture if you want, but Parkinson's disease, nerve palsy. So again, I know that facial Bell's palsy and third nerve palsy have come up recently. Neuropathies, myasthenia gravis, and then all of these other things in between. I had cervical spondylosis, and it was basically an elderly gentleman with a spastic paraparesis, and he had a scar at the back of his neck. So never forget to look for scars in every examination, including neurology. And someone asked us on the WhatsApp group recently in terms of like when to examine gait. I would do that at the beginning because that can give you the diagnosis immediately. Like with my patient, he stood up, he walked, he had a spastic paraparesis. I knew this is either MS or this is going to be trauma or spondylosis. Like I had the three differentials already in my head. And as I was saying, you can kind of break it down by region of the nervous system, or you can do it like this sensory. If it's sensory, you're thinking neuropathy. If it's motor, it's either going to be upper motor neuron or lower motor neuron. If it's cerebellar, these are your differentials. If it's multimodality, then it's going to be demyelination, like MS, or you have rarer causes of demyelination, like neuromyelitis optica, etc. So this is another way that you can think about how to break down your neurological conditions. Station 4 is abdo and then comms, which we discussed earlier. But with abdo, it's actually probably one of the more straightforward sort of things. It's either going to be a liver case, in which case they're going to have hepatomegaly or cirrhosis. Spleen is rare, but you might get splenomegaly in the context of like a myelofibrosis or a hematological condition. Kidney transplants, SPK transplants, these are super common. Polycystic kidney disease can come up. Bowel stuff that can come up, inflammatory bowel disease with some scars. So if they've got multiple scars across their abdomen and then fairly young, think inflammatory bowel disease. Hernia stuff, actually, one person mentioned to me that they had a hernia scar which caught them out recently. Um, that sort of stuff's a bit rarer. It's a bit unfortunate, but it can come up. Okay, good. So now you have your list of cases. You can go away onto the wards and actually try and find those cases. This is how I approach my presentation. So there's a few ways you can do this. Um, you can either use the left or the right. And my preference is to use this one in green. But neither is right or wrong. So let's start with the one in the left. So I examined a 50-year-old gentleman. So you start off with, just quick statement of what you did. Examined a 60-year-old's cardiovascular system. Then you move on to the bedside. So at the bedside, there were or were not any paraphernalia of respiratory disease. Then you move on to inspection. So the patient looked well at rest. Keep this short. If they looked well at rest, then just the patient looked well. That's it. Don't need to say like their respiratory rate was normal, they weren't diaphoretic, etc., etc. Just the patient looked well. And if they didn't look well, then say, okay, the patient looked tachypneic on inspection or whatever it might be. Then you move on to the periphery. So there were no peripheral stigmata or respiratory disease. My main findings on the precordium were that, then you work through it systematically, starting off with palpation / expansion, percussion, auscultation, and then move on to your negative findings. So there were no, and you mentioned your relevant negative findings. So in the context of respiratory exam, as this is what we're working with here, you can usually say there were no signs of right heart failure or cor pulmonale because the patient is probably quite unwell if they were in cor pulmonale. So this is one complication that you can think about, or you can say the patient was not cyanotic, because the patient's unlikely to be cyanotic if they're in a PACES exam. And then you want to have a list of complications that you want to mention for each examination. So for abdo liver, you want to say the patient was not jaundiced. Obviously, they are jaundiced, don't say that. But as an example, the relevant negative in a liver case is that you want to tell the examiner that the patient isn't in acute liver failure. So you can say the patient was not jaundiced. There was no ascites, although, if there was, obviously, don't say it. But you get what I'm saying. And then you conclude, and then differentials. So this is one way you can do it. It's a bit long-winded in my opinion, but yeah, it works for some people. I much prefer just to keep it short and sweet because, like I said, the examiner just wants something concise. So I examined a 60-year-old gentleman. My positive findings were, XYZ. My negative findings were XYZ. These are my differentials, and this is why I conclude. So that's just short and sweet. And this is what I prefer, and this is what I advise. Just to list your positive findings, list your negative findings and keep it to relevant negative findings. So like I said before, don't go through every sign related to heart failure. Just there were no findings consistent with heart failure, and then move on. When you're vivering, always give three differentials for everything. I know sometimes, okay, it might not be possible, but largely it is possible, okay? If you have splenomegaly, you might think of infection, hematological malignancy, portal hypertension. I'm not interested in Gaucher's disease. Even if that is the case, if that patient has Gaucher's disease, but you say Gaucher's disease is like the top of your differential, that's quite strange. So list the common things first and don't mention rare things unless they really do have a bund or rare diagnosis. Um, but yeah, just stick to common things because you're not going to be wrong for saying a patient with splenomegaly might have a hematological malignancy, but you will look foolish for saying they have Gaucher's disease. Um, the examiner will ask you questions, just answer them succinctly. Like I said, don't say I think or it could be this or that. If they've asked you a question, just get to the point and answer it. So again, to practice the rule of three, let's say I have a patient with hepatomegaly. What are the three differentials that you're going to give to the examiner for hepatomegaly? Okay, good. We got taker. So you said cirrhosis, cancer, non-alcoholic fatty liver disease. Yeah, three very reasonable differentials. The only thing is, I would say, as we've got heart failure, hepatitis, abscess. Okay, so so liver is quite an interesting one in that obviously cirrhosis can be alcoholic or it can also be non-alcoholic. So to say cirrhosis and then NAFLD, it's not wrong, but like I would just try and be a bit more specific. So what I teach and what is also in cases for PACES is the three C's. So, cardiac failure, cirrhosis, cancer. That's it. Cardiac failure can comfortably cause hepatomegaly, as can cancer, and as can alcoholic cirrhosis, or you can say non-alcoholic cirrhosis. Things like abscesses, I wouldn't mention because it's rare and the patient won't have an abscess in the exam, but it's a good thought. Um, and yeah, you guys are along the right lines, but try and keep it to the commonest things. These are the seven domains that you're tested across: physical examination, identifying physical signs, clinical communication, differential diagnosis, clinical judgment, managing patient concerns, and maintaining patient welfare. And remember, the one that people fall short on are the physical signs and the differential diagnosis. Physical signs, don't make stuff up. I know I said this, but I'm going to say it again. Don't make stuff up. If you're unsure, it's better to err on the side of caution, in my opinion. Okay. And differential diagnosis, give three. Um, think of a way in which, if you are unsure, you can convey that uncertainty in your presentation, but I wouldn't commit if if you think you felt a collapsing pulse. I wouldn't commit to it unless you're sure it's there. And that's the end, really. I'm going to take questions. I'm going to stick around. So please do ask any questions and do tune into our course. Oh, I should have probably said there is a discount because you attended the webinar. So if you input webinar 20, you get a £20 discount. Put that in the chat. And yeah, happy to take any questions. Please do join our WhatsApp group as you can find out about our upcoming webinars. Our next one's next Tuesday, and that's by a stroke consultant. He's going to cover some neurology stuff for us. And then after that, we have one on ophthalmology and then one on clinical consultation. So please do tune in, and those are completely free. Anyone's welcome to attend. And yeah, hopefully I'll see some of you at our upcoming course. But please do ask away if you do have any questions. I'll stick around for 5 or so minutes. So I've been asked, missed the first 5 minutes of the webinar. What was the first step? So I was just saying the first step is really to nail your examination routines. So practice, 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 and practice on healthy individuals, friends, family. Like the first step shouldn't be going into the ward and looking for signs. If you haven't got your routine slick, don't go to the wards. Get the routine slick first. The signs will always be in the hospital, right? Patients are always going to be there. So I wouldn't waste your time. It's just not an efficient use of your time to see patients first. Get the routine slick. That's basically what I was saying. Is there anything else? Thanks, Finn. That's really kind of you to say. So I wanted to ask for your tips on keeping yourself accountable during preparation. Yeah, that's a good question. I mean, that's kind of like a more of a personal thing because obviously some people are very good at being disciplined and some people aren't. So you need to know your personality type. I think what helps is knowing your exam date. Once you have your exam date penciled in the calendar, you kind of know it's looming and around the corner. But I think what you're trying to ask is like kind of where should you be at each stage of your preparation? And I think right now, you guys don't know when your exam is, but there's no excuse. You need to have your examination routines nailed. Like, and that's something you should be working on in the next week. That's what I would advise. Uh, and if you take it in the steps I showed you, if you say you've got 8 weeks till your exam, the first week should be spent nailing your examination routine. And then the bulk of your practice should be spent practicing clinical consultation with friends and going on the wards and hunting signs. And then when you're at home, practicing viva preparation. But I think a good way to hold yourself accountable is I wouldn't be too worried about what your friends are doing. But if, let's say, a month before the exam, I think that's a good marker, like 4 weeks, 3, 4 weeks before the exam. You definitely need to have the examination routines nailed. You definitely at that point need to be going to the wards and having seen a lot of the common conditions. You should at that point have seen aortic stenosis, aortic regurgitation, valve replacement, Parkinson's disease, a few basic nerve palsies, interstitial lung disease. And that's where you should be at a month before your exam. And if you're at that point where you've seen a lot of common cases, you've nailed your examination routine, you practice clinical consultation with friends, I think then you're in that, you're on a good path. Harry has asked, do you think ophthalmoscopy is key to learn? I don't really think so, to be honest. I think it's a bit of a waste of time, but it's one of those things that like comes up once in a blue moon. And if it does come up and you don't know how to at least use the fundoscope, that's that station down the drain. So whilst I don't think it's key to learn, I think it's just important to know how to use the ophthalmoscope at the very least. And I can tell you that it's probably going to be retinitis pigmentosa or some sort of bond or diabetic eye disease. Um, I tried to go to an ophthalmology clinic in preparation for my PACES, and I think they dilated the patients. And I'm going to be honest, I still had no idea what I was looking at. So I would just get comfortable with using the ophthalmoscope, knowing what those dials do, um, and then maybe looking at some pictures on the internet of what the common stuff that you're going to get in PACES are, like retinitis pigmentosa, etc. And that's what the webinar is going to cover in a couple of weeks. I honestly wouldn't spend too much time on it, basically. Oh, sorry, I didn't realize we have a Q&A as well for people asking questions in there. Hmm. Okay, there is a Q&A function, but for some reason I can't open it. So if you could just ask your questions in the chat, please, that would be appreciated. I've recently started registered stroke. I don't have Okay, this is a good question. So basically someone who started working in hospital, but basically doesn't have much access to general medicine, has access to stroke, renal, urology, and vascular. I mean, you'd be surprised what you can find in those. Like vascular is a great place to find medical conditions. They all have renal failure. They all got diabetes. They might have peripheral neuropathies. But yeah, it's not efficient because what you want is you want a patient with a diagnosis of known peripheral neuropathy, known Parkinson's disease, known interstitial lung disease. So what I would suggest there is you may need to then take a trip to a different hospital and try and arrange a placement at a different hospital. So what I did is I had a friend who worked at a tertiary hospital, and I went there for a day, for example. If you contact a consultant, because usually you'll be part of a trust, right? So the way the trust works is usually you have like a couple of small hospitals and then one massive hospital. So if you speak to some consultants at the big hospital in your trust, you shouldn't have an issue with accessing it because you're part of that hospital trust. So I think from like an indemnity point of view, it's probably okay, but just double check that with the consultant. Just email a couple of the general medical consultants in the bigger hospital and ask them to like, if you can come for a week placement or if even for a day, you can go to their acute admissions ward. That's a good place to start. On top of that, the video banks and YouTube. Plenty of free content on YouTube, video banks, and go on a course, right? That's where you're going to see patients. With the neuro exam, should you ask? With the neuro exam, should we ask the patient to close their eyes when checking sensation? Yeah, I would ask the patient to close their eyes because otherwise then they could be biased by what they're seeing, right? If they see you touch them, then they might say yes. So you should ask them to close their eyes, get the cotton wool, tap it on their chest. Can you feel this? Okay, that's what it's going to feel like. And let me know, just say yes when you can feel this, and then you start tapping them. So yeah. Cool. That's everything. Again, sorry for those who ask questions in the Q&A. For some reason, I can't access it. So if you did want to re-ask your question, put it in the chat, please. Okay, cool. I think, should we wrap up there? I think it's probably everything. Um, Okay, cool. Thanks, everyone. Thanks so much for attending. Like I said, QR code for the WhatsApp group is there. QR code for the website to join us on our course is there. Webinar 20 is the discount code. You can also WhatsApp message me if you're on part of the WhatsApp group. You probably have my number. So, anyone's welcome to contact me anytime. Happy to help where possible. And yeah, take it easy. Hopefully, I'll see some of you in the future webinars and in person in the course. Best of luck with your preparation, everyone. Take care.